Okay, so hi everyone, I'm Rous. I'm a thoracic medical oncologist at Henry Ford in Detroit, Michigan. Today I'll be talking about newer types of treatment for lung cancer. So specifically, I'll be talking about antibody-drug conjugates and bispecifics. These are my disclosures, and this is the agenda for today. So we're going to talk about ADCs and bispecific antibodies. We're going to talk about the components and structure, mechanism of action, mechanism of resistance, talk about some examples, and then future perspectives. Okay, so let's start with ADC. So what are the components of ADC? So let's say that you're in your kitchen on a Saturday morning and you want to cook up an ADC. What do you need? What are the ingredients that you need in order to make an ADC? So in order to have an ADC, you need a target, right? Because it stands for an antibody-drug conjugate. Actually, let's start with the antibody. You're going to hear me say antibody today like a lot of times. So we need to understand what is an antibody. So an antibody is a protein that has two arms that bind to a target. And then these are what's called the Fab or the FAB portions. And then you have the FC portion. So what is the FC portion? It's basically the part of the antibody that is used to activate the immune system. So you need that antibody, you need the target, right? And this way you have a functioning antibody. And then in order to have it as an ADC, you need to conjugate chemotherapy to it. So this is basically the payload. And then you need the linker between the payload and the antibody. Joshua Sabari, who is at NYU, once called it chemotherapy on a stick. And since then, I can't think of it in a different way. So it's basically a stick, which is the antibody, and there is chemotherapy on it. Or in other ways, you can think about it as a chemo mailman, right? So you have your mail, which is the chemo particle, and the mailman being the antibody, and then it delivers the mail to the cancer cell, hopefully in a very specific way. Okay, so let's try to break it down and talk about each of these ingredients. So starting with the antibody, there are many types of antibodies: IgG, IgA, IgM, IgE. Each of them has its own characteristics, but the most widely used antibodies in ADCs are IgG. Why? Because they have higher specificity and affinity to the target antigen that you're trying to basically target. They have a favorable PK, which means that the body processes the IgGs in a very favorable way, making it short, a reasonable half-life and a reasonable basically like the window where it's the efficacy window where it's the ratio between the efficacy and the toxicity is very favorable. It has minimal immunogenicity, which means that it's not gonna be targeted by the immune cells and destroyed once it enters the body, but at the same time, it's able to elicit an immune response through the FC portion that we talked about. And then because they're small compared to other types of antibodies, such as IgM, the cancer cell can internalize that IgG, and then it can kill the cancer cell from the inside. And we're going to talk about the mechanisms of actions in a little bit. Okay, the second type or the second ingredient of the antibody drug conjugate is the antigen. It's not technically a part of the antibody drug conjugate, but it's a very important component for the ADC to work. So what is an antigen? Antigen is a protein that is expressed, or a molecule that is expressed on the cancer cell, right? And as you all know, in cancer, there is really no black and white. So this molecule can be expressed also in normal cells, right? Or most of these or all of these molecules are expressed on normal cells as well as the cancer cells. But for us to choose a winner target, we need that target to be preferentially expressed or in higher levels on the cancer cells, so that the effects are mostly on the cancer cell rather than the normal cell. And then that protein or that target or that antigen needs to be important to the cancer cell, right? Because we're trying to target the machinery of the cancer cell and kill it. Then that protein or antigen needs to be very important in the cancer cell machinery. And then when you have your antibody, right, and then you have your mailbox, or you have the package, that you're trying to deliver, which is the payload. We're going to talk about it next. You need to attach it to the antibody. So you have your mailman, you have your package, you need to attach them to each other, and then you have the linker, or basically the glue. Some glues are the ones that we used to use in school. They don't work, so these are the cleavable linkers. But some of them are super glue. They work really, really well, and these are the non-cleavable linkers. And each of them have their own pros and cons at the same time. The cleavable linkers, they work in a way that it's good enough to attach the chemo to the antibody, but then because they're cleavable, they can be released in the bloodstream on their way to the cancer cell, and that can cause some side effects. Whereas the non-cleavable linker, they bind the antibody to the chemo, or the chemo to the antibody very very well that in order for it to work, the cancer cell has to destroy the whole complex or digest the whole complex for the chemo to be released. These both of them have their own technical pros and cons, but these are the two types of linkers or glues that we have: the cleavable and the non-cleavable linkers. And then we have our payload or the chemo package that the mailman is trying to deliver. And this is basically, very small nanoparticles of chemotherapy, but that chemotherapy has to be potent at these very low or nano concentrations and has to be able to be conjugated, right? So you're not going to choose a chemotherapy that cannot be glued to the cancer to the antibody. I can't claim that I know exactly how that how that works, but I'm sure our scientists and pharma industries, when they're trying to design an ADC, they think about the chemo that is amenable to conjugation to the antibody, and then usually the types of these chemotherapies that are conjugated to the antibodies work by damaging the DNA of the cancer cell or managing the tubules that the cancer cell use in order to replicate its DNA. So it targets the core machinery of the cancer cell itself. And then there's a very important principle that we all have to understand when we're talking about ADC, and it's called DAR, or drug antibody ratio. So it's very simple. So it's basically what is the ratio between the chemotherapy particles and the antibody. So how many chemotherapy particles are linked or conjugated or glued to that one antibody. We always have one antibody particle. The DAR is how many chemotherapy particles are attached to it, and that affects our efficacy as well as toxicity. So higher DAR means higher efficacy, but possibly higher toxicity. Lower DAR means lower toxicity and potentially lower efficacy. So the most approved ADC have a DAR between 2 to 8. So either 2 to 8 particles of chemotherapy are attached to that one antibody. So these are the components that we need in order to make our own ADC. We need the antibody, the chemo, the linker, the target, and then we need to understand the DAR, or the drug antibody ratio. So how